Thank you very much. You can pick up your check later for the introduction. Okay, thank you for inviting me, to the organizers, Stefan, and thank you for being here bright and early. I know immunological challenges is not your favorite topic, possibly, and most of us are cardiologists because we like pressures and colors and hands-on work, and T cells and B cells give us shivers. But I'll keep it very practical, and hopefully that's helping. My corruption score is fairly low, and it's mostly because of having a couple of grants that are mostly governmental. So what I would like to talk about, and Stefan has asked me to go a bit over time, which is always an easy task, is just very briefly about the transplant outcomes, because you'll notice a lot of the slides are going to overlap with what Stefan has just shown us. But a bit more into the mechanisms of sensitization against HLA and what the effect of antibodies is. Just a brief word about how the techniques have changed and how that impacts our interpretation. Therapy options of antibody-mediated rejection, and then the impact of ABO incompatibility. I've just added that last night because of the additional time. This is just some interesting image from adult transplantation for congenital heart disease. And as you can see here, they have this early, so the blue ones are the adult congenitals, and the orange ones are the non-congenitals. And you see they have a big drop, big mortality early on, but in the long term, they're actually doing much better than the non-congenitals. And this is true for the single study as well as for a meta-analysis that has shown exactly the same things pretty much throughout the study. So this explains to you why the surgeons don't like adult congenitals and the cardiologists like adult congenitals. And we see a very similar picture, as Stefan has shown us, if we look at survival of very young patients. So here you have the less than 1-year-olds in the purple curve, and you see that they have high early mortality, probably because they're typically very sick going into transplantation. But then especially if we look at the conditional survival after the first year, they do better than anybody later in life. And just to kind of mirror what Stefan was saying, I think we've come a really long way. If we take today's curves and extrapolate them, we're probably looking at 30, 35 years, 50% survival for our patients. I think that's a pretty good option. Now, it's not always true for everybody. So being young and being in cardiomyopathy is great. Even with congenital heart disease, survival looks pretty good. But that's only true if they haven't been really touched before. And the reality for us nowadays is almost all of our patients have had previous surgeries. And that significantly drops your survival post-transplant as well. And why is that the case? Because this is just one example how typically the patients look by the time that our surgeons come and say, oh, now this guy needs a transplant. So you have a terrible function. You have, this is a cleanse stage, but you see there's also a stent in the isthmus already. There's a covered stent in the nominate vein to cut off all the collaterals. And this is the situation. This was a patient that came to us from a different center that has said this patient cannot be transplanted anymore because she was 99.9% HLA sensitized by the time. And this is actually well documented in a couple of papers like this one, showing that, yes, if you had previous surgeries, if you were on a VAD, if you have congenital heart disease, particularly if you have a previous Norwood, your likelihood of being sensitized is very high. Now, what's the role of the Norwood here? The Norwood, as you all know, typically, or most centers still use homografts, so human vascular tissue to reconstruct the aorta in that situation. And with these homografts come all of the HLA antigens that the donor has. And every day we create about 1 million random B cells, and they'll just swim around the blood and look for their fitting part, and if they find it, they get activated. Now, if it's like this, they might just do that for a short time, but they might also develop memory, and that memory sits in the local lymph nodes and in the spleen, and is ready to produce antibodies as soon as, for example, a heart later gets transplanted that has the same surfaces. And this happens in the first days of life. So this is a study actually from Edmonton where they have compared use of homografts in the gray ones and no homografts in the black. And you see that these all newborns have 80% chance of being sensitized from a homograft if it's not pre-treated. Now, why would a VAD sensitize us? It's an artificial surface, and there's actually nice pathological data about that as well. So similarly, antigen-presenting cells will actually cover the VAD surfaces at some areas, at least, where kind of it enters into the circulation. And then T cells go there, and we get this inflammatory environment there, as we know from our coagulation and from other things that go off. CRP is usually high for a while and things like that. And so what can happen in this situation is we can have just random bystander activation. So same story, we have a random B cell, it swims through these highly inflammatory milieu and gets activated. Now they don't find their antigen, so typically they only exist for a short period and then they will die off. So this is often what we see as transient antibodies. We can also have memory reactivation. So maybe I had a homograft 10 years ago, now I get a VAD, and the immune system gets pushed again, and that memory that was hibernating becomes active again, and that's a more persistent variant of immune response that will arise from that. Lastly, we get new sensitization, because it's very rare that we would have a VAD without having blood products. Platelets express HLA class 1. Most of the blood products are not completely free of leukocytes, so we can have interaction with new HLA antigens and thereby have new sensitization while on a VAD. And this actually happens, and this is one of our own studies, but it's similar in many other studies. So we find about 30% new sensitization on VAD, and we also find patients that ramp up their antibodies that they had before. And that typically happens very early after the implantation of the VAD. Later on, it's very rare that we get new sensitization or changes in sensitization. But it is relevant. This is just data using PRA, so just kind of broadly whether somebody was sensitized or not sensitized, and you can see that survival by having a PRA of more than 50% is reduced by about 20%, and this is true for the overall survival as well as the conditional survival. If they're donor-specific antibodies, they obviously play a specific role because then their target is the organ that was transplanted. And as you can see here, quite a bit of a difference in terms of survival. This is an older paper that has gone by cross-match. So if I actually have antibodies that not only bind to the donor cells but also cause damage to them, it's a very negative prognostic sign. For sure, it's not this situation anymore that nobody survives beyond 6 years, but it is a significant risk factor. And then this paper was just recently showing that both graft vasculopathy as survival are significantly reduced by donor-specific antibodies. If you look at the numbers, though, you see that they had a 10-year survival in the DSA negatives of only about 65%. So it's not surprising that the head of this department in the meantime has changed. But why are they harmful? So there's two effects that the antibodies have, and now we imagine this is not the homograft, but this is actually the coronary of the transplanted organ. And one effect is what we all know and what we measure with our biopsies. It's complement activation. So complement directly puts harm on the cells, and that's what we actually measure as antibody-mediated rejection in our immune fluorescence, and we get these kind of perivascular, beautifully looking images that are not beautiful at all for the patient because we're in trouble. But that's not the only effect. I think the more crucial effect is actually what's called opsonization. Opsonization means it's like dipping a strawberry in chocolate. It makes it much more likely that you eat it. And that's the same effect for macrophages and antigen-presenting cells because they follow this gradient of antibodies and invade the vascular wall. And then they pull more T cells. We didn't know that antibody-presenting cells, antigen-presenting cells look like that, hey? And they produce more B cells, and then we get endothelial proliferation, we get fibrosis, we get swelling of the vascular wall, and it's exactly what Stefan showed us, now much nicer to be seen in OCT, but in IVUS as well, you get this big swelling, and obviously that narrows down your coronaries and is basically the correlate of graft vasculopathy. We can also acquire HLA antibodies passively. So every mom, typically they're not married to their identical twin, so they will have HLA antibodies after their first pregnancy. And they transfer them via placenta to their babies. So they will have mom's antibodies. They also get the antibodies that are in plasma that they get or that are in IVIG at times. So sometimes we have to be careful with how to interpret those antibodies. And they can also be a result of transient non-specific activation, similar to what I said with the VAD implantation. Same thing happens with EBV infection, CMV infection at times. And this is an interesting paper from Claire Irving showing that those transient even if they are donor-specific antibodies, don't seem to really cause much harm because they're not reflective of a true immune response. While if you have persistent donor-specific antibodies, the effect is very significant on survival. Now, the other thing that has changed a lot in HLA is the techniques of detecting antibodies has dramatically evolved. So the sensitivity of our current techniques, mostly flow PRA and Luminex now, is dramatically higher, and we pick up a lot of antibodies that we wouldn't have picked up with the old cellular tests. And therefore, we have to be careful on how to interpret that. Not every antibody that we find now has the same negative effect than what we would have found 15 years ago. Now, what can we do to avoid these negative effects? Ideally, we would have identical twins for everybody, right? But even in the identical twin situation, live donation of hearts has become pretty rare. So typically, that's not an option we have. You would like to match as good as possible, which they can do in kidney, they can do in bone marrow, but since we're depending on deceased donors, that's not an option. What most places, as we do, is we look for antibodies before transplantation. And if antibodies are there, we try to avoid them. And we can calculate something called the CPRA. I think here people call it a virtual PRA, a calculated PRA. And what that is it takes these antibodies that are there and calculates how often are they in the population of your donors, which means you can have a lot of A67, 68, whatever else that are very rare and still only have about 5% of the donors that are not suitable. You can have only A2 and 60% of your donors are not suitable for you anymore. And that's why we use that technique to kind of get a sense, how likely is it for us to find an organ. And then, of course, not limits, but limits. Also blood group, because if your blood group O and AB are not an option anymore, then your donor pool becomes pretty small. So in Canada, we have a nice system for the last 6 years or so. That's called the status 4S, and that gives nationwide priority to highly sensitized patients for a perfect match. So if there's a perfect match coming up anywhere in the country, then that patient gets priority, and that avoids these people waiting for 8 or 10 years for an organ. However, it's not always the best thing maybe to look into the optimal match. This is an interesting study from the US, and you have to keep in mind they have completely different wait times. The average wait time for a status 4 patient in the US is 21 days. And during those 21 days, they already reject about 6 hearts. So they have between 30 and 50 offers a month, which is what we have about a year. And so they can be more choosy. But even in that situation, they found that if you have highly urgent patients that are very sick, the downside of having a positive cross-match, which costs you about 20% of your post-transplant survival, is actually outweighed by the downside of dying while waiting for the perfect match. So they found that up to 30% higher mortality in high-risk patients, it is more reasonable to just take the next best organ and try and deal with it. What else can we do? Could we avoid homograft-induced HLA sensitization? So people have tried that actually for a long time, and they've started giving IVIG during the surgery and giving mycophenolate during the surgery. But the reality is it hasn't really worked. The sensitization still happened. Why does it not work? Because if you think about it, you would have to lifelong immune suppress them to avoid it, because the homograft stays in there. It's always going to be there, so that doesn't really work. Now, the surgeons before I was there in Edmonton came up with this very neat approach, and what they do is they treat the homografts with glutaraldehyde, and that depletes it of all cells. And with that approach, where there's simply no antigen to be activated against, we have less than 15% of sensitization in our Norwood patients. Now, people are always worried that it could impact your Norwood outcomes, and it's only a smaller group of the Norwoods that end up with the transplantation. So we've looked at that just recently, and indeed we found that the cath interventions to the isthmus are a bit more frequent in those that have had treated homograft, but in general, there's not more surgeries, there's similar survival, so from our perspective, it's very much worth it to do that. And you can just do it yourself with glutaraldehyde. You don't have to buy the new US-based commercial product that is decellularized homografts. Now, what to do if we have antibodies? It's just quickly important to remind how the naive B cell with CD19 and CD20 becomes a plasma cell, which then produces the antibody but doesn't express CD20 anymore. And that's where the antibodies in the end come from, but we also produce memory B cells that can reactivate into plasma cells quickly if we get exposed to the same antigen again. Now we can try, or we should try, and get rid of the antibodies, and we can do that with plasmapheresis, which is a fairly crude technique because it takes out all the proteins. So we always have trouble with our coagulation, we have trouble with removing our tacronymus, or ATG, or whatever else we're using. So it's nice to have more specific ways, and there's columns that specifically remove the FC receptor, so only IgG gets removed. There is columns that specifically remove A and B antibodies for ABO-incompatible transplantations. And there's a new technique that's just been presented last year called IDAS, which is streptococcal protease, which does not deplete the antibodies, but basically splits them and makes them inactive. And that seems to be equally effective. There's just 2-3 new papers. So that may be a big step for the future. Now, I think it makes little sense to remove the antibodies if you still have new supplies of it. So I think every protocol also needs to include rituximab. And that depletes our B cells. Keep in mind, not the plasma cells, because they don't have CD20 anymore. So therefore, it is a delayed effect. So it takes about 2-3 months until you really see the antibodies come down when you use rituximab only. If you need a faster effect, or if you don't have enough effect, you can use bortezomib, or now carfilzomib is a newer drug that apparently has less side effects to deplete your plasma cells. Also has an effect on memory B cells. And that works really quick and effectively, but it also has quite significant adverse effects. We don't know very well yet about the desensitization in multiple myeloma that it originally was developed for. They have up to 55% polyneuropathy, which is typically transient, but it's quite a significant concern. And then lastly, IVIG, immunoglobulins, help us for everything because they give them back protection against infections after we remove or deplete their immunoglobulins, but they also slow down the body's own protection of harmful antibodies. And they modify how the IgG can bind to its receptor, to surfaces, so you basically just cover every receptor, and that way you don't have as much downstream reaction, even if the antibodies are there. So from my point of view, every protocol that deals with antibody-mediated rejection or sensitization should include some sort of antibody removal if I have to, if I don't have the time to wait for it to come down. B-cell depletion and IVIG. So we typically start, if we have patients on the wait list, we would start with rituximab and then give IVIG and wait for 3 months and see if it comes down, and then have proteasome inhibitors as our back option. And at the time of transplantation, we can always remove remaining antibodies if we have to. Now, the dark horse in this whole situation are these guys here, the so-called long-lived plasma cells. We know very little about them, but they seem to sit somewhere in the long bones in an immune-privileged area of fatty tissue and not be reached by anything. And they produce low grades of antibodies. That's why even 15 years after a tetanus vaccination, we still have a few antibodies left there. And it's not clear if we can reach them with any of our therapies. Lastly, what we can do is go with the downstream effects. So we can, of course, use steroids. That's actually part of most of the bortezomib protocols anyway, because it makes it more effective. If we're in a situation of acute rejection, we can use ATG because it's rare that it would be only antibodies. We always have a cellular component as well. mTOR inhibitors, as Stefan was saying, have a specific effect on proliferation of endothelial cells, so they can mediate the damage as well. And then there's eculizumab that basically just blocks complement activation of the antibodies, so it removes all effectiveness, but it's a very high risk in terms of infection because even your IVIG gets completely blocked from it, so you have no effect of any antibodies anymore. There's fairly little clinical data. There's a study from Toronto from a longer time ago when they just did all these things at the time of transplant, and they thought it was reasonable in terms of their outcomes. There's a couple of pre-desensitization studies, so pre-treating your sensitized patients, then crossing the antibodies, and they typically seem to work reasonably well. There's a smaller series from Kurt Schumacher from Michigan in pediatric hearts. We have done 8 patients like that now with excellent success so far. However, the impact on long-term survival and graft vasculopathy at this time is completely unclear. And there is some signs that, for example, in kidney, if you have late graft vasculopathy or glomerulopathy, how they call it, that the therapies don't really make as much of a difference anymore. So I am very skeptical that in a situation as Stefan has shown, where we already have graft vasculopathy, by removing the antibodies, we can reverse that effect. I think once the train is running, it's really hard to stop it. Now, as I say, all of this is what people currently do, so we follow the crowd, and we think it's the right thing to do, but hopefully we're not getting surprised in the future. Now, Stefan asked me to add a little bit about ABO-incompatible transplant, which obviously is my passion anyway, and I also feel that Europe is still a little bit behind in that aspect, so I'm happy to talk about that. And it's really important here to see that the nature of antigens is very different. So HLA is a protein. It goes through T cells, antigen-presenting cells, B cell activation. A and B antigens are polysaccharides. They're sugars, and they don't fit into the MHC2 complex. So they can't go this pathway unless they get conjugated to a protein. You all know that story from the Haemophilus influenza type B and pneumococcus and meningococcus vaccines. If you're a baby, the first 2 years you don't respond to the pure polysaccharide unless it's combined as a conjugate vaccine with a protein. And we're using this gap in the immune system to do ABO-incompatible transplants. And initially that was done just out of desperation. So they had about 55% waitlist mortality in infants in Toronto in the mid-90s. And they said, well, lots of those kids don't have A antibodies, they don't have B antibodies, which is usually until 6 to 24 months of age. Let's just try and see if they can get through that. And they were rewarded with seeing that actually the survival was similar and is to this day. And the really interesting thing around that was that we found that these patients never come up with antibodies against A or B, depending on what their donor is. So if you're blood group O, usually you would get anti-A and anti-B antibodies. If you're blood group O and you get a B heart, you develop normal anti-A antibodies, but no anti-B antibodies. And we're looking now at 25 years, and we still have lots of young adults now that have not developed those antibodies. So that's a really interesting thing, and we found that that has to do with modified B-cell maturation and with modified crosstalk with the complement system as possible reasons for that. And then one really interesting surprise finding that we had, because we thought, of course, we have another antigen that doesn't fit, so they are more likely to be sensitized. But reality is they're actually less likely to develop antibodies against class 2, and we had published that in 2010. Fortunately, in the meantime, 2 other centers have found the same thing. So this seems to be a true effect that is actually a potential benefit of an ABO-incompatible transplant. So this is brand new data, was only presented at ISHLT this year. It's, of course, $19.99, not $999. And we have now overseen 364 children that had transplantation in the first 2 years of life with an ABO-incompatible organ. 25 are older than 2 years of age, and we haven't included them in this study just because that wasn't really our question. Now, interesting, as shown in previous papers, still to this point, people reserve ABO-incompatible for the sicker patients. So they were younger, they had a lower BSA, they were more likely to have congenital heart disease, more likely to be on ventilator, ECMO, or bed. They were higher listing urgency status, and of course, blood group O was more common in the ABO-incompatibles, and blood group AB shouldn't actually be at all in the ABO-incompatibles because there is no incompatible for them. And because they had a different risk profile, we actually did a matching, but we did not a propensity match or something like that, but a direct matching. So for every ABO-incompatible patient, we have chosen 2 compatible patients that were same age, same underlying diagnosis, and same status in regards to VAD or ECMO. And this is just how it has evolved. And as Stefan said, pediatric heart transplant study group is mostly North America. There's the UK, and there's Canada and Brazil, and then about 45 centers are from the United States. And what you can see here is since 2010, since people were saying, oh yeah, I wanted to take an ABO-incompatible, it has now increased to about 70% of the less than 2-year-olds that get listed for an ABO-incompatible in North America. And this is the number of transplants, and as I mentioned so these were all Canadian patients, and then there were a couple of UK patients coming on top of it, and since 2010 they can do it in the US as well. And as you can see here now, about up to 35-40% of the patients get actually an ABO-incompatible heart in the age group of less than 2 years of age. Now, is there a benefit of doing that? Waitlist survival was the same between groups, and so was the likelihood of being removed from the waitlist, but the time to getting an organ was significantly shorter if you were listed for an ABO incompatible. Now, you have to keep in mind that by allocating ABO incompatible hearts, you also make more hearts available for the ones that get a compatible heart. So that may underestimate the benefit that you have, and the overall benefit may be larger than this, but that's hard to assess because you would have to go back in time to and then there are so many other factors that play into that. Survival post-transplant was similar, and I'll have a bit more data on that, with one exception, and those are these patients, which were the ones that were initially listed for ABO compatible only and then switched over to ABO incompatible. And what you think is probably those are patients that have deteriorated. So people got desperate and said, okay, we just have to get an organ for this patient. And in reality, that's what we found in those patients. So they had an increase in need for mechanical support. They had an increase in the waiting list urgency. And this is now taking all the patients and looking at survival, and this is now for 15 years. And again, these are all patients. These are not the original experimental, highly watched patients. These are patients that were done for clinical routine. And you can see that the survival is equal between the two groups. The blue ones are the incompatibles here. Same is true for graft vasculopathy and for incidence of PTLD or malignancy. So all of those were similar. Now, the really interesting and surprising thing was that rejection is actually less common in patients that have received the ABO incompatible transplant. And even more surprising was that infection was less common as well, because we thought we changed their immune system, so maybe they're more prone to get infections, but it turns out it's not the case. And this is really exciting from an immunological perspective because it's basically the idea of a reverse effect of the conjugate vaccine. So conjugate vaccine, the B cell binds the polysaccharide, the T cell looks at the protein part, and this way a T cell can activate the B cell. Now here we see that possibly this also works the other way around. So if we have a non-responsive B cell to a polysaccharide, that may also impact what happens with the HLA response to the same organ. And what's the clinical situation? So all this fear about ABO incompatible goes back to these early reports from the 90s where almost everybody died that got an ABO incompatible heart. Now, interestingly, 2 or 3 years ago, somebody went back, used the ISHLT database, and they found that about 90 patients in the adult world had received accidental ABO incompatibles. And they did find a high mortality of about 35% in the first year, but after that they did the same as the compatible ones, which could suggest that if you treat them the right way in the beginning and avoid this early mortality, you could end up with the same outcomes. And in Sweden, they have, in 2012, done 2 patients like that, and that they pre-treated and did adult incompatible transplant. Newcastle, that's another place that pushes the boundaries, had a 9-year-old, and we had up to a 6-year-old now, which interestingly was a patient that had fully developed antibodies against A and B, and we desensitized her for HLA, and her A and B antibodies came down, and then we just bit the bullet and said, let's do an ABO incompatible. That was a really good HLA match, and she's now 9 months post doing well, and the other one that was 4-year-old is now 7 years after ABO incompatible transplant. So what are the boundaries? It's kind of spring in Alberta, so you can see that there is something coming in the future, but not quite there yet, so we don't have all the answers. But I do think it is a pretty good and useful option. Thank you.